Hello and welcome to UOA On Demand. Tonight we'll be discussing the rotator cuff. My name is Dr. Michael Liu. I am a shoulder and elbow orthopedic surgeon. Joining me tonight are Dr. Chris Doumas, a hand upper extremity orthopedic surgeon, and Dr. Ken Swan, a sports medicine orthopedic surgeon. Gentlemen, thanks for being here.
Thank you.
Good to be here.
So let's get started. Dr. Doumas, can you tell me what is the rotator cuff?
So the rotator cuff is basically the mobilizer of the shoulder. So it's the motor of the shoulder, as we like to call it. It's got basically four tendons that surround the shoulder joint that basically envelop the ball and socket and basically move the shoulder around and start the motion, whether it's elevation, rotation, things of that nature. So four tendons make up the rotator cuff.
So Dr. Swan, can you tell me why are rotator cuff problems so common?
Rotator cuff problems are common because disease or injuries to the rotator cuff tend to be a function of age. The older people get, the more commonly they have an issue with the rotator cuff. The rotator cuff tends to get thinner and weaker as we get older. And really, it's not that old. Once we get into our late 40s, into our 50s, the rotator cuff will start to develop some age-related degeneration that makes it more susceptible to injuries and strains and inflammation.
Right, so wear and tear problems, repetitive use injury. What about things like trauma?
Absolutely. So you're correct in that wear and tear plays a role, and then the shoulder may be acting up, or it may not even be bothering someone at all, but may have some wear and tear to it, and then a trauma, sometimes minor or sometimes more significant, like a trauma with a shoulder dislocation. The status of the rotator cuff can change dramatically in the form of a big tear, a massive tear, or perhaps a smaller strain on the rotator cuff.
Right. So Dr. Doumas, Dr. Swan just mentioned a variety of rotator cuff problems, whether it's strain or tears. Can you tell me about the spectrum of injury, whether it's impingement, partial thickness tears, full thickness tears?
Sure. So it depends in various populations how you're going to get an injury or a problem with your rotator cuff. Certain athletes can have certain types of partial thickness tears, whether that be on the undersurface in throwing athletes, whether that be on the bursal side. I always try to explain it as the rotator cuff has really got almost two layers to it. It's got a top layer on the bursal side, a bottom layer on the joint side, and you can tear any part of that, and you can tear them in different directions. Meaning you can have one part torn on one side and another and have an oblique type of a tear going through the tendon. You can have them fully retracted off of the bone if you have the entire tendon torn. You can have just a small portion of it torn off the bone. So, that's in the actual tear episodes. Sometimes it's just degenerative change that you see in the tendon, where it's just a change in the actual matrix of the tendon at the insertion from overuse, from chronic tendonitis, things of that nature. You can have calcifications that also form in these tendons as well. That can occur over time and can give significant pain when some of that calcification leaks out into the bursa.
Right. So Dr. Swan, what kind of problems or what kind of symptoms will someone have if they have rotator cuff problems?
The main symptom will be pain. And that pain can be mild pain that bothers them with certain activities of daily living, reaching. Oftentimes they'll mention reaching in the back of their car, reaching for their seatbelt. Those types of maneuvers can cause pain, but they can have pain at rest as well. And oftentimes it's that pain when they're trying to sleep that will be the biggest issue. When people can't sleep, that's when they often seek treatment. So then that's when they often will finally come to the office. So pain would be the main symptom, both at rest and with activity, but also weakness can develop. If there's a significant tear of the rotator cuff, the shoulder will be, at times, can be demonstrably weak, either to the patient's own understanding or when we examine them in the office. In addition, so that's pain, that's weakness, and then stiffness can play a role, certainly when there's impingement, so inflammation and tendonitis of the rotator cuff. Patients often have some stiffness, in particular, sort of reaching behind their back, what we call internal rotation. That will be an additional symptom.
Right. So Dr. Doumas, can you tell me what a pseudoparalytic shoulder is in the setting of a massive rotator cuff tear?
Sure. So usually that's related to trauma or somebody who's had a previous injury to the shoulder and then develops a new onset injury. That could be more subtle, but it can actually basically mean that all the tendons rip off of the shoulder. And so, that can be any portion of them, but usually it's more than one that's going to occur when you have this. And we call it pseudoparalytic because there's not a nerve problem going on. It's that the muscles are trying to fire, but because that part of the tendon that attaches the muscle to the bone is no longer attached, you really can't raise your arm up. So you're basically, trying to raise your arm like this and you just can't do it. So you hike your shoulder, but you can't actually elevate your arm to the proper position that you're trying to.
Right. So I think the key is that the patient can't actively do it. They want to do it, but they can't raise their arm overhead. But when you're examining them, you can actually raise their arm for them. So that it's not just pure stiffness, it's actually muscular dysfunction or, a tendon problem in this particular case. So we spoke about how a pseudoparalytic shoulder is really just a shoulder that can't be moved by the patient because the muscle, the arm won't go overhead. So what kind of traumatic or acute settings can we see this in, Dr. Swan?
Yeah, so you may see that in a patient who has dislocated their shoulder. So when someone dislocates their shoulder, that's a traumatic injury that is not fun. That hurts. It gets popped back into place, typically in the emergency room, and then the patient feels much better. When it's a young person, like in their, say, teens or 20s, the thing we worry about there is that shoulder may dislocate again when they get back to their activity or their sporting or their skateboarding or whatever. In someone who's older than that, it's say 40s and over, we're not so much worried about that shoulder dislocating again. The chances of that aren't very high. However, the older you get, if you suffer a shoulder dislocation, there's a much higher chance that you've torn your rotator cuff. So if a patient has dislocated their shoulder, and now once that pain starts to subside, they start to realize that, hey, I can't move my arm well. Is that just the dislocation, and is that going to get better? There's a very good chance if they're 60 or 70 or 80, there's a very good chance that they tore their rotator cuff and may have torn it badly, and they probably ought to be seen sort of sooner rather than later. And that might be a patient that I get that MRI sooner rather than later to not miss that new big traumatic rotator cuff tear.
Right. So the algorithm kind of changes depending on what the patient presents with.
Yeah, sure.
So Dr. Swan, can you tell me, does every rotator cuff tear cause pain?
No. In fact, as we mentioned earlier, rotator cuff tears are degenerative tears, ones that don't necessarily happen with a trauma, but just happen over time as people age. Those are very common, and if you took MRIs of all the 80 and 90-year-olds out there, you'd find a lot of rotator cuff tears that aren't causing any pain and perhaps aren't even causing all that much weakness. People can accommodate and adapt pretty well. Sometimes we don't fully understand how they're actually doing it, but no, a rotator cuff tear does not necessarily cause pain.
Right. So Dr. Doumas, does that mean that every patient who comes in to see you needs an MRI of their shoulder if they have shoulder pain?
No, not at all. I'm actually very conservative in ordering the MRIs. I think one of the biggest things that goes on these days is people don't examine their patients well enough to get a good clinical exam, because MRIs are so ubiquitous right down the street or in their own offices. And so it's a strain on the healthcare system, number one. Number two is there's very often incidental findings on the MRI that have nothing to do with actual causes for pain in the actual examination. So I think the exam is very key. I don't routinely order MRIs right away unless there is a traumatic episode and there's significant weakness found on the exam. Most of the things you can try to decipher clinically that you don't really need an MRI. And for me, an MRI, I always explain to people, is really a gateway to an operation, because if you're not going to change your management based on the information that you're getting from that imaging study, there's really no need to get it at that point. So.
Right. So Dr. Swan, say someone comes to see you in the office, they have a complaint of shoulder pain, no trauma, it's just been ongoing for a few months now. What would they expect when they walk in the door?
So I'll try and decipher that history a little bit better. How long has it been going on? What might have started it? No trauma, but maybe they were doing some heavy snow shoveling a few weeks ago, or raking in the fall. How much is it affecting them? Important to know the history in terms of how bad is this pain? Can they sleep? How much agony are they in? Because that may help dictate how we're going to treat this. So a good history, of course. A physical exam, like Dr. Doumas suggested, is very important for us to help figure out, is this indeed the rotator cuff? Do they have a frozen shoulder? Is it impingement? There's several diagnoses that it could be, but we'll start with a good history. We'll get a good physical exam. Almost always we're going to obtain shoulder radiographs, plain x-rays, 2 or 3 x-rays to check for arthritis, to check for any bone spurs, to check for any calcium deposits, and then we go from there. That combination should help us really narrow down our diagnosis. And if we do think it's a rotator cuff issue, depending on the patient's age, amount of weakness, if there's no trauma, there's a very good chance this patient will be heading down the road of physical therapy and medications and perhaps a cortisone injection.
Dr. Swan, so you mentioned cortisone shots, physical therapy, anti-inflammatories as really the first-line treatment options for non-operative care rotator cuff problems. What do you think about PRP, or platelet-rich plasma?
Right. So PRP has gained a lot of press, and it's a relatively popular question to ask. Platelet-rich plasma is when a test tube of blood is drawn from your veins, from your arm. It's spun in a centrifuge, and then the growth factors that are associated with the platelets can be used and injected back into part of your body, whether that be your shoulder for your rotator cuff or other parts of your bodies, to try and theoretically help those structures heal. The science in theory is very hopeful and it does make some sense, but the data and the literature has not fully supported this as of yet. There are some studies that show some promise, and so some practitioners are using this in a variety of ailments, including the rotator cuff. So that can be used either potentially in the office as an injection, or perhaps in the operating room as a supplement to a rotator cuff repair.
Right, so PRP is an option for some rotator cuff problems, but it's really not the gold standard.
Agreed.
Okay, so
I guess I would add that as of yet, insurance doesn't cover it, so it ends up being a big out-of-pocket expense for the patient.
Good point. So we've gone through a variety of non-operative treatment options for rotator cuff problems, whether it's physical therapy, anti-inflammatories, cortisone injections, the controversial PRP injection. Let's talk about some different surgical options for rotator cuff problems. Dr. Doumas, say you had impingement or calcific tendonitis, what could you do for that surgically?
So, typically you go in with a plan to do, everything depending on what you find when you're doing a shoulder arthroscopy. So you have all the tools in the shed with you, as well as the, anchors, which is what we call some of the implants that we put into the shoulders. Basically, simple things you can do for rotator cuff pathology is making more space for the rotator cuff. Everybody probably has, and their mother's probably heard of somebody having a bone spur removed in their shoulder, and that's typically what you do for an impingement type case. Where the top shelf of the shoulder here, the undersurface of the bone there can impinge on the rotator cuff, and so you can smooth that surface out. You also do that typically on a lot of cases where you do a rotator cuff repair, not necessarily to make more space per se, but also just to stimulate some bleeding in the area, to try to stimulate some growth factors, as we were discussing before with the PRP, and some of the thoughts behind that as well. For calcific tendonitis, you can remove some of that calcification from the tendons. And sometimes you're left with a small hole, sometimes you're left with a big hole, depending on the size of the calcification. And in some of those cases, you do need to actually fix the tendon down to the bone after you remove the calcification as well. Some of the more traumatic ruptures of the tendons, again, also if you're going in, you're going to be fixing them down surgically with suture anchors, which is basically like little grommets or wall anchors that you would take for carpentry and hanging things on the wall. And they actually have stitches that come out of them. So you basically implant those into the bone and then pass the sutures through the tendon to repair that tendon surface back down to the bone.
Right. So the key is trying to bring that torn tendon back to the bone where it tore off from.
Correct.
Right. Dr. Swan, so say the tear is too massive, the tendon quality is too poor, the tendon won't reach back to where it tore off from. What are some other options then?
Yeah, that can be a challenging scenario, and it actually is something that we see with some frequency in that the rotator cuff tear is so big from being sort of chronic, or perhaps a new fall, a new trauma to that shoulder really created a very large tear that will be very difficult to repair back to where it came from, or if you do repair it back to where it came from, it might re-tear. So you can reinforce that repair with a patch. There's a variety of options out there, but basically an allograft specimen of tissue to help cover and support your repair. In addition, there's maneuvers where you can slide tendons that from elsewhere around the shoulder to help cover the hole that's otherwise irreparable. That's a bigger operation that sometimes requires an open surgery rather than an arthroscopic surgery. And then getting sort of into additional options, if someone has an irreparable tear, and if their shoulder is starting to develop arthropathy or degenerative arthritic changes related to that chronic big rotator cuff tear, they could be a candidate for a shoulder replacement, and in that scenario, a reverse shoulder replacement.
Right. So Dr. Doumas, you mentioned having, basically the kitchen sink available when you're going in for a shoulder arthroscopy to be able to really tackle any problems that you encounter during the time of surgery. Does that mean if you see a problem on the MRI and the patient has complaints and physical exam findings with their acromioclavicular joint or with their biceps tendon, that you would potentially address those problems at the same time during the arthroscopic surgery as well?
Yes, that's correct. The good part is most of the things that you need to take care of in a shoulder, you can do arthroscopically through some small incisions. And it means much less pain going forward than the way that they used to get done in the past when you had open incisions that would extend all the way across the front and the side of the shoulder. So through small little incisions now we can have the tools to really take care of the majority of problems in the shoulder. I think one of the key points also is before doing any of these things, it's just making sure that the range of motion is appropriate before doing anything surgical in a shoulder. I always tell my patients, if you're starting stiff, you're going to end up stiff. And so, sometimes you need pre-op physical therapy if there is a little bit of a frozen shoulder, or what we call adhesive capsulitis, where the shoulder just is stiff passively when I can't move their arm all the way up over their head to the proper position. That's not a candidate for going in for a rotator cuff repair right off the bat. So, really getting that range of motion back near normal is extremely important preoperatively before the surgery, especially. So.
Right. So that's a very good point. Preoperative physical therapy is important as postoperative physical therapy. So Dr. Swan, what can patients expect after an arthroscopic rotator cuff repair? Describe the road to recovery for me.
So the surgery, when we do it arthroscopically, that's small incisions, about that big, 2, 3, 4, sometimes 6 or 7 small incisions around the shoulder to get our instruments inside and repair the rotator cuff. But we're still doing the whole surgery. We're still fixing that whole rotator cuff. And as Dr. Doumas said, other things may be involved as well, shaving down bone spurs, taking care of the biceps tendon. So there's still a lot of work done on the inside. And it takes a while for that to heal. You have to give it a chance to heal. So I try and let my patients know that this is not an easy recovery. When you walk out of that operating room, it's not like, oh, my shoulder feels better. When your nerve block wears off, you may have a fair share of discomfort for a few days there or up to a week or so. You're in a sling for a solid month, I think most of us would probably say, sometimes 6 weeks, depending on the size of the rotator cuff tear. And you're really not supposed to use that shoulder much at all for the first 4 to 6 weeks. You can use your elbow and you can use your hand, but you're not doing anything with the shoulder. You're not supposed to drive, and you do need some help around the house. You need someone to help you change and shower and get around and get to and from places. So it's important for people to understand that the first month or so is challenging and difficult, and you just have to prepare for that. And then once you get through that, you get into your therapy and you get moving, you get your independence back.
Dr. Doumas, how long do you tell people it takes to fully recover, as good as you're going to get from a rotator cuff repair?
Right. And so again, I lay a lot of crepe in the beginning and explain to them that this is a long recovery. This is not 6 weeks I'll be back at work or I'll be swinging a golf club type of a surgery. It depends on the size of the tear. It depends on the aggressiveness of the patient. It depends on the age of the patient sometimes as well. My typical scenario that I tell people is that about 3 to 4 months, you're going to be doing most things, but still with some pain, still with some stiffness, and still with weakness. It's really a 6-month recovery in my eyes for most people to get back to doing pretty much most of the things that they want to do. But they'll continue even at that point to improve up to a year. If there's still issues, at that point, you can worry about, re-tears and things like that. We didn't talk a lot about complications, but there are complications that do occur. And although uncommon, re-tearing is one of the ones that we don't like the most, because sometimes either therapists are too aggressive, patients are too aggressive, or they have poor bone quality and things can sort of fall apart. And so that's one of the real risks of the surgery that I think we all worry about. And that's why we have, really regimented rehab programs to try to prevent that from happening. So again, I caution the patients a lot preoperatively so that they know, what to expect and what to fear as well. So they know what not to do. So.
Right. So Dr. Swan, say someone has an office job and, they work at a desk. When would you expect them to be able to go back to work?
I think 2 weeks would be a reasonable amount of time there. They could be back at their desk, relatively comfortable, using a keyboard or computer, using their phone, and not reaching for things. And then getting to and from work is a little difficult. You're really not supposed to drive when you're still in that sling. But I think if you can get to work, you can probably do it.
Right. So
vastly different.
Would they be, so they in the sling still, they may be on narcotic pain medication still. So driving is, not a great idea in that situation at all.
Not a good idea in that situation.
What about someone who's a manual laborer? Say they're a steam fitter or they work in HVAC. When would you allow them to go back to work?
Yeah, so much different scenario there, and that's going to be a longer road to recovery. So for my protocol, it'd be at least 3 months until they're back to doing what they do, and it may be closer to 4 months till they feel ready, but they're probably allowed to do it at 3 months. Meaning, it'd be interesting to hear, but I think my protocol may be different than you guys. But for me, for let's say a big tear, I have them in a sling for 6 weeks. I do very little for the first 3 to 4 weeks. I start therapy at around that time, 3 to 4 weeks, just passive range of motion up until the 6 week mark. At 6 weeks, they're allowed to start doing active range of motion where they lift their arm with the help of the therapist's guidance. But they're not doing any resistance, trying to strengthen it until about the 10 week mark. And so if that's true, 10 weeks, 2.5 months to get back to their job where they're actually lifting things against gravity and working, it's probably 4 months.
Yeah, I think I'd probably actually be a little bit more cautious than that. Maybe I'm just chicken, but I think that still has pain, a lot of weakness overhead. I would not want to be the steam fitter working with the guy who just had surgery, trying to hold a 50-pound pipe over my head. But
yeah, good point. Good point. I didn't know what a steam fitter was.
So Dr. Doumas, you also mentioned some other possible complications for surgery. Do you want to talk about any other ones that come to mind?
Well, you can always have them from anesthesia. I mean, that's always one of the biggest things you worry about. Just being, we usually do these. Some people do them on their side when they do shoulder arthroscopy. Some people do them in a beach chair position where they're sitting upright a little bit. And so there is, a higher risk of stroke not a high one, but a higher risk of stroke in the beach chair position that you have to mention to everybody. So there are those anesthetic risks that you get. There's risks of infection, but they're very, very small in arthroscopy because you're flushing a lot of water through as you're doing these things. So you're literally cleaning it out as you're doing the procedure. You can have some reactions to some of the suture anchors and things of that nature. Again, those are very, very rare. I think the biggest ones you worry about, I always explain to people, is just persistent pain. And I think the best way to explain that is, people come into our office expecting to be normal, but they're not coming into our office normal. And so I was explaining to them, my job isn't to make you normal again. I'm making you different in a better way. And so I think that's one of those things that you try to explain to people to get through. When you have a massive rotator cuff tear, your shoulder's never normal again, or even a small one. It's not normal once you have an operation, but better in a different way. And so that's really the best way to explain it. I think the re-tear is probably the biggest concern that we all have with these types of shoulder surgeries. So.
Yeah, and I think I agree with all those. I think you mentioned at some point you mentioned stiffness. It's a little bit of a trade-off, but we have you in a sling for a while, 6 weeks oftentimes, not doing very much, and you do get a little stiff from that. And sometimes people get more than a little stiff. Usually that works itself out over the course of 4, 5, 6 months. But sometimes it takes a little longer for that stiffness to go away, and that can be a complication if it's persistently stiff, and we need to address it surgically in very rare instances.
Right. Stiffness is definitely a critical factor. What role does diabetes play in rotator cuff repairs?
So diabetes plays a role in a lot of things orthopedic, which many patients may not initially be aware of, but diabetes certainly affects tissue healing. So bone healing, wound healing, and then rotator cuffs, which by their very nature are often not the best quality of tissue. That's part of the reason they tore in the beginning. For that to heal back to the bone, if you're a diabetic certainly if you're a not well-controlled diabetic, your chances of healing that tendon aren't going to be as good.
Gentlemen, thanks for being on the call tonight. So just in summary, we discussed rotator cuff problems, the spectrum of pathology, whether it's impingement, partial tears, full thickness tears. We talked about the anatomy involved with the rotator cuff and what exactly it does with overhead activity and stability in the shoulder, problems that patients may present with in terms of pain, weakness, dysfunction, difficulty sleeping. We talked about the physical examination findings, X-ray findings, MRI findings. We also spoke about what they might expect when they come to the office in terms of getting a good history and physical examination to try to figure out what the actual problems are. We spoke about operative treatments, including physical therapy, anti-inflammatories, cortisone injections, and the controversial platelet-rich plasma injection. We spoke about different surgical treatment options for rotator cuff problems. And we spoke about the possible complications following surgery and the postoperative course following surgery as well. So I'd like to thank you guys for being on the call. It found it to be very informative. Hopefully the audience out there found it to be educational as well. I would like to invite the audience out there to contact us, online, uoanj.com. Find us on Facebook, Twitter, Instagram, for any orthopedic issues, shoulder problems, back problems, any orthopedic problems whatsoever. We're also available for second opinions. You may be seeing another physician for your shoulder pain. And if you're having second thoughts about going for surgery or you're not happy with your current care, come and find us. We're more than happy to get second opinions. We're also available via telemedicine as well.